So, so I'm also recording the session. So after class, I'll be able to share the recording so that you can have time and go through it, and also maybe use it for future references. So once more, good evening, all of you. It's my pleasure to welcome you to this two-day series of enteral nutrition for cancer patients. This is just a series of training that we have been organizing. Last month we did adrenal insufficiency, and we really learned a lot um, under adrenal insufficiency. Today we are looking at enteral nutrition for cancer patients. I think last year we did parenteral nutrition for cancer patients. So it is a point of learning. The reason as to why we are organizing this program is because cancer is an emerging chronic disease, and many nutritionists really are struggling to manage it, especially coming with different nutritional concerns. So it is important that we are equipped with information to manage our patients, even as we think of how we can specialize in this different area of cancer. So today I'm going to take you through an interesting session on just what enteral nutrition is for cancer patients and different areas. So I hope you'll be able to follow the presentation, and also we can have question later on. So I had already introduced myself. My name is Kennedy Okinda. I'm a nutritionist by profession. I've specialized in oncology care for cancer patients. I'm a licensed oncology nutrition specialist. I'm also a research officer, and among other things that I don't want to take my time to do right now because of already time is gone. So our presentation today, we are going to learn something on indications, contraindications, complications, and monitoring of enteral nutrition for cancer patients. And I hope by the end of day one, we'll be able to understand the main indications and contraindications for enteral nutrition for cancer patients. We'll be able to identify cancer patients who might benefit from enteral nutrition. We'll be able to understand the most important complications of enteral for cancer patients, and also to know how to prevent or counteract complications, and how to know how to and also we are going to learn how to know how to monitor patients on enteral nutritional support. So this is going to be today's learning objectives. Then hopefully tomorrow we'll cover something continuation on complications of enteral feeding, and we are going to do a case study so that we really align with what we are learning. So that is how we are going to learn for today. So by introduction, I know we are having different level of colleagues here. There are those who are gurus in this field of nutrition, and there are those who have just joined, who graduated recently. So I made this presentation to be as lean as possible so that we capture the both population, the extremes. We have those who are just new in the field and those who have been practicing for long. So it is good to define these terms so that it is important for us to understand what we are dealing with. So enteral nutrition basically refers to any method of artificial feeding that uses the gastrointestinal tract to deliver part or all of calorie requirements. So we have different ways people get nutrition or nutrients. The first one is through the mouth, which we call oral nutrition. This is mostly for people who are not sick or who are sick, but they have their mouth is able to work normally. So they can eat by mouth. Then, of course, we have enteral nutrition. So, enteral nutrition basically are people who are not able to chew, or they have challenges with their mouth, and therefore they need a tube feeding, or they'll need a tube pass from their nose to the stomach, or they can do mouth to stomach, or they can bypass stomach. I mean, they can bypass the mouth, the esophagus, and also go insert the tube within the stomach. So basically, then the last one is parenteral feeds. Basically, this delivering of nutrients into the veins. directly. So enteral feeding, by definition, is just the artificial feeding that uses the gastrointestinal tract to deliver part or all calorie. So it includes the use of oral nutritional supplements or delivery of part or all of the daily requirements by use of nasogastric, enteral or percutaneous gastric or jejunal tube feeding. So those are some of the methods that we can use to deliver nutrients through oral nutrition. So we can either use what we called uh, the tubes that have been listed there. We have the what we call the nasogastric tube, enteral or what we call PEG tube or jejunal tube. Then enteral nutrition is a safe, it is effective, and generally well tolerated approach to nutritional therapy in patients with a normal or relatively normally functional gastrointestinal tract. So it is quite safe, and the good thing again, it is quite effective, and generally it is well tolerated approach to nutritional therapy in patients, especially cancer patients with normal or relatively normally functioning gastrointestinal tract. So, by introduction, by definition, for those who didn't understand what enteral feeding is, that is what we are going to talk about. Of course, the main goal of enteral nutrition in cancer patients is prevention or treatment of malnutrition in order to improve outcome. So just to give you a background, cancer patients really experience severe wasting syndrome. And this is necessitated by several factors. The first factor that necessitates this wasting syndrome is what we call the tumor itself, what we call tumor-related factor. So how this happens is that tumor releases what we call cytokinins, which are what we call immune modulators. They are usually produced in results when we have infection going on or inflammatory process. So cytokinins really have several ways of causing malnutrition. They affect the appetite, so they affect the central nervous system, they affect the liver, they affect the muscles, and they also in a way affect the heart. Another way by which cancer patients experience malnutrition is through the treatment modalities for different cancers. For instance, if a patient is undergoing radiation therapy, they usually experience what we call mucositis, which is usually the inflammation of the mucous membrane. This in results cause wounds within the GIT, and therefore the patient will not be able to feed well. Another aspect is this patient having what we call complications of chemotherapy, for example, nausea and vomiting, which is quite common for cancer patients. So this in turn may lead them not to feed adequately, or sometimes they tend to avoid food. So for cancer patients, they have a multifaceted way of which they experience malnutrition. And at the end of all this, they have a condition called cancer cachexia, which is a wasting syndrome, which is characterized by muscle wasting and also what we called uh, inability to feed correctly. So looking at enteral nutrition, the main objective for cancer patient is just to prevent malnutrition, or in one way to treat if we find it early. So this is obvious from a pathophysiological point of view, but there's also strong evidence from a number of excellent studies which show that malnutrition is an independent risk factor for increased morbidity and mortality rates. So malnutrition itself can cause mortality, it can cause disease. So we have malnutrition cycle, disease, and cycle of malnutrition. And if you look at the cycle, the malnutrition itself can cause a disease, or the disease itself can cause a malnutrition. So, in a way, for cancer patients, it is the same way it applies. Then, of course, we're talking about length of hospital stay. Uh, Most of you who are working in the hospital setup understand that most of the patients who spend much time in the ward are cancer patients. If you go to the oncology ward, they take longer. And most of the time, why they stay longer is because of malnutrition. Then, of course, we have worsening of functional status. So for cancer patients, we have what we call ECOG score. ECOG score is basically a functionality score this is definitely to look at the functions of the body of a cancer patient. So I'll share what ECOG score is in details in the WhatsApp group, so you can also follow up the conversation. So ECOG score is a functionality score that is showing how functional physically is the cancer patient is. For instance, a cancer patient with the ECOG score of 4, basically they mean this patient is totally bedridden and they depend on another person to help them. And ECOG score of 5 is a dead person. So I'll be able to give you those ECOG score to understand. And then of course we have higher treatment cost for cancer patients is another reason why malnutrition is should be addressed. As expected, treatment of malnutrition results in improved clinical outcomes, including longer survival and fewer hospital readmission rates. Therefore, once cancer patients who need nutrition support have been correctly identified, the appropriate nutrition treatment should be chosen and delivered timely. So it is important for us to have timely delivery. What I want to emphasize, and the reason as to why this in training is very important, is that currently Kenya we get referral late for cancer cases. Many nutritionists usually meet cancer patients at the tail end when mostly we are dealing with palliative care rather than curative. So you find in continuum of care of these patients, they have gone through so many phases. By the time they are referred to a nutritionist for care, it is too late. And again, they already have what we call cancer cachexia syndrome, which again is a irreversible wasting condition. So why this awareness is important is because then it will help us again to have a discussion with doctors, because cancer care is a multidisciplinary approach. So it is important that we tend to have this patient at early phase, even before we get the ideal diagnosis, so that we can start helping these patients at early phase. And I also want to emphasize that uh, enteral feeding for cancer patients do not only apply when the diagnosis has been confirmed. It starts even when we have suspicion. So don't shy away from recommending enteral feeding as early as possible. So irrespective of the type of cancer or clinical setting, enteral nutrition should be considered and usually administered to maintain or improve nutritional status in patients at nutritional risk, those who are malnourished, and in those who cannot meet their nutrient requirements by oral dietary intake, and are also expected to experience inadequate oral intake for more than 7 days. But they have a functional gastrointestinal tract and agree to the treatment. So, indications that you need to look into, especially for cancer patients: one, they have to be at nutritional risk. And there are several tools that we use to identify the nutritional risk for cancer patients. One of them is called MUST, Malnutrition Universal Screening Tool. It is one of the recommended tools for screening. We have nutritional risk assessment tool. So we have several tools that we can use to do nutritional assessment. And right now, the conversation is moving away from the use of reliability of BMI alone to diagnose nutritional malnutrition for patients, not only for cancer, but overall patients. It is important that now we start advocating for bioelectric analysis, full body composition, because it will give us really an accurate analysis and accurate figures. So malnutrition in cancer patients is a nutritional disorder which includes starvation-related underweight, cachexia, what we call disease-related malnutrition, and there's something we call sarcopenia or frailty. So I'll explain. Sarcopenia basically applies to muscle wasting, even for patients who have maybe an obese, have been categorized under obese patients. So sarcopenic obesity occurs when you have severe loss of muscle mass for patients, especially cancer patients. So you find that maybe we have a patient with breast cancer, but they are overweight or they are obese. Many people tend, if you use the BMI, you'll find that that patient is normal, probably is overweight or obese, and therefore maybe you feel like you don't want, you cannot intervene to support them nutritionally. But yet, if you do the full body composition, you'll notice that majorly the weight is composed of fat rather than muscles. So sarcopenic obesity is one of the things that enteral nutrition tends to address. And of course, we have sarcopenia that occurs severe muscle loss secondary to disease itself or maybe starvation. So indication that you need to have in mind is basically looking at those points. So I was able to take you to develop this flow chart to share it so that we can be able to guide us for cancer patients how we do it. So we start here by risk screening, and risk screening is at risk for malnutrition. Use a validated screening tools, and I've said one example of a validated screening tool is MUST, malnutrition universal screening tool, that can help you. Again, another tool that is also very important and that can give accuracy is what we call PG SGA, patient generated uh, tool. It's also a good tool that actually for cancer patients, that's the tool that we use for nutritional assessment. I'll share it in the group so that you can have a view of how it works. Then, of course, we have diagnostic assessment. So for diagnosis to be done, there are two criteria that has to be met. One, we have what we call phenotypic. So phenotypic, we look at the weight loss, we look at the low body mass index, and we use at reduced muscle mass. Then, of course, we have etiological. Basically, this is reduced food intake or assimilation, disease burden, or inflammatory condition. So these are the parameters or criteria that we use to do what? To diagnose malnutrition for cancer patients. So for diagnosis, it must meet it meets criteria for malnutrition diagnosis, require at least one phenotypic criterion and one etiological criteria. So that really will definitely give you a picture. If a patient has weight loss and still they have reduced food intake, basically that is a patient that has met the criteria for intervention. I hope up to that point to Kopamoja. Are we together? Are you following? Is it okay? Am I
Yes,
making
we are
okay?
following.
All right. So for us to make thank you. For us to make a better diagnosis, we have to have at least two, one phenotypic criteria and one etiologic criteria. So that one, it can either, if the patient has low body mass index and still they are into acute inflammatory process, let's say maybe they are having acute illness. If you do CRP, what you call creatinine C-reactive protein, then you'll find that it is, if it is elevated, then basically this patient is having inflammatory process going on, then that is a key marker of malnutrition. So you can see that many cancer patients meet all these criteria. You find they have weight loss, they have low body mass index, they have reduced muscle mass. At the same time, they have reduced food intake. So they fall into category of malnutrition without even thinking twice. Then, of course, severity grading determines severity of multi. So severity is based on phenotypic criteria. So basically, if it is weight loss, we look at by what percentage is weight loss. So that that is also another important thing that we need to know. What percentage is weight loss? Is it 5%, more than 5% in the last 6 months, or more than 10% in the last 6 months? For red and cancer patients, usually they have quite uh, crazy weight loss of, let's say, almost more than 10% weight loss in the last 6 months. That really is a determinant. Now, so after you've really classified your patient based on that criteria, of course, the best is to use the validated tools. Then now we go to enteral nutrition is just like the first choice in at-risk or malnourished cancer patients who are unable to meet their calorie and protein targets by oral feeding and are affected by one or more variety of conditions that interfere with oral intake. So enteral nutrition is one of the first choice. So before we explore the parenteral, which again we studied in our previous symposium, so note that for patients who are unable to feed orally, they need to transit to enteral before you now make a choice of going to parenteral. So indications include one, which patients can benefit from enteral nutrition, situations associated with reduced level of consciousness or cognition. So this might happen for patients who are having either brain tumors, which is known to affect the consciousness, or we have what we call oncological emergency. I'll discuss that in a moment. So such patients also may experience unconsciousness, and or sometimes they might not be stable to eat orally. Number two, neurological disorders and basically brain tumors. Those patients might will benefit from enteral nutrition. Head, neck, and upper gastrointestinal tract cancers is what they automatically will benefit from enteral nutrition support. Inherited disorders secondary to cancer. For example, we have oncological emergencies. So, what oncological emergencies by definition is, you find that if the tumor has the capability of forming its own blood cells, it has the capability of forming its own hormones, it has the capability of forming its own enzymes. That means it can function independently, but I mean it can function independently, but over reliant on the body nutrients. So if tumor is able to produce, let's say, for example, we have one of the oncological emergency is called syndrome of of inappropriate antidiuretic hormone. So we understand that antidiuretic hormone is one of the is able to regulate the sodium level in the kidneys. But since if a patient has cancer, has tumor, the tumor will be able to produce more of antidiuretic hormone than the body requires, because they mimic the same hormones that body produces. So when that occurs, you'll find that there is going to be an elevated sodium level because of the overproduction of antidiuretic hormone. So this in turn really is going to cause a problem. So it's one of the oncological emergencies that to be checked for. Hyperglycemia is one of the oncological emergencies. So tumor itself is capable of causing elevated blood sugar, and that again is one of the oncological emergencies. So all that may necessitate enteral intervention. Then, of course, during periods of decreased oral intake, anticipated less than 50% of required nutrient intake orally for 7 to 10 days. So if you know that this patient is not able to take 50% orally, don't even think twice. Put that patient, and this is going to be more than 7 to 10 days, put that patient on enteral nutrition support. If this patient is going to have metabolic stress, as I've said, especially in the inflammatory process, acute process of illness, enteral nutrition will be adequate. If this patient has a tumor in the abdomen and they are going to have abdominal resection, low output fistulas, patient is in coma, consider enteral nutrition for such patients. Malnourished cancer patients expected to be unable to eat for more than 5 days, they are going to qualify for enteral. Normally nourished cancer patients expected to be unable to eat for like more than 5 days, especially maybe if we anticipate that they are going to start radiation therapy and this is going to affect their intake, start advocating for enteral nutrition immediately. Then, of course, we have adaptive phase of short bowel syndrome following surgical trauma. From if cancer patients have gone through cervical trauma, if they experience burns, also they are going to benefit. So, in these situations, enteral nutrition has proven to be effective in preventing weight loss and maintaining nutritional status. Remember, that is our main key role that we intend to support this patient with. Now, so we've looked at indications. So now all the patients that will meet that criteria, then they'll have to be considered for enteral nutrition. What are some of the contraindications for enteral nutrition for cancer patients? So the first one is what we call severe functional disturbances of the bowel. So this is just to let you know that not all cancer patients might benefit from enteral nutrition. So you might have to filter them out. So if a patient has under category of severe functional disturbances of the bowel, for example, we have what we call malassimilation or loss of nutrient, that is in short bowel syndrome, intestinal ischemia, small bowel mucosal disease, high output fistula, and severe nausea and vomiting, then such patients you might stop or reconsider providing them with enteral nutrition because it will not benefit them so much. Then, of course, we have gastrointestinal obstruction, what we term as ileus. If a patient is going to experience peritonitis, stenosis or strictures, for example, we have pyloric stricture and stenosis, inflammatory disease, peritoneal carcinomatosis, then this patient definitely you'll have to consider parenteral feeding for them. Now, metabolic instability, I've talked about what we call oncological emergency. So metabolic instability like diabetic ketoacidosis, it's not like this patient have diabetes, but now because of the tumor itself, which is producing hormone what you call tumor like for example they produce the same hormones or enzyme the body produces, then they cause elevation the disturbance in metabolic process, then those patients might not, you might not put them onto enteral feeding. For instance, if you have a patient with diabetic ketoacidosis, diabetic coma or hepatic coma secondary to what we call oncological emergencies, those patients may not benefit. Then, of course, circulatory instability. Here we are looking at severe acute cardiac insufficiency, shock of any origin. So mostly the practice is cancer patients before they are started on certain chemotherapy, medication, or radiotherapy, they go through echo to check if their heart is okay. So if the echo is done and the patient have severe acute cardiac insufficiency or shock of any origin, then that patient will not benefit for enteral nutrition. So what the option do you have? You have parenteral feeds to consider for that patient. I hope up to that point we are together. So we've covered introduction, we've been able to cover indications, we've looked at the contraindications for enteral feeding for cancer patients. So I think let's look at now the route of enteral nutrition for cancer patients. I hope we are following the conversation. If you have a question, you can either stop and ask, or maybe you can type in the chat box. I'll be able to have a look at them as time goes by. Are we together? Maybe I can have some reaction if you are doing well. Great, great, great. I can see some people are following. So let's look at routes of enteral access for cancer patients. So they are more or less the same for other normal patients, but for cancer patients, again, the requirements might be different. So tomorrow we'll do a case study for you to now get to know practically how to manage a patient. So this is just a background information, but for us to really get to understand, because after this webinar, we expect that you are going to manage your patients at home. So tomorrow I've prepared a case study that we'll be able to discuss. We'll be able to do some calculations so that you get the practicality of what we are learning. But routes of enteral access. One, regarding routes of enteral nutrition, there is a useful distinction between short-term and long-term feeding. So before you decide which route are you going to use, then you need to understand how long this patient is going to be on enteral nutrition. It is very important to put that in mind, okay? So that we don't just decide without understanding. So if the patient is going to be on short term, we are going to see which routes are feasible. If patient is going to be on long-term feeding, we are going to look at which cases is feasible. So for patients who are going to fall under category of long-term, are, for example, patients who are going to undergo radiation therapy for head and neck cancer. So for such patient, we do fix what we call prophylactic gastrectomy tube. Basically, we are looking at the patient who we are going to have gastrectomy tube in advance before they start radiation therapy, because we know radiation therapy is basically going to affect their oral intake. So we insert the tube early. Such patient, you anticipate them to be on a long-term feeding. Then for short-term feeding, for instance, is a patient who maybe they are going to be on chemotherapy, which is going to affect their oral intake, and after the chemotherapy cycle, then you'll give them few days for them to proceed. So before you decide on which route to give, make sure that you are able to know for how long, and that's why multidisciplinary approach is important. For how long is this patient going to be without feeding? So several methods of enteral access for nutritional support are quite available. So in everyday practice, nasogastric tube, which is NGT, nasoenteric, which is NET, PEG tube, PEG, and what we call fine needle catheter jejunostomy are most commonly used. So our attention will be directed more towards this technique. So I'll be able to discuss all these techniques so that we understand the route of feeding. So nasogastric feeding is the least expensive and easiest way to gain enteral feeding access, and is the preferred route for short-term enteral feeding. PEG is usually indicated when the patient is expected to need tube feeding for longer than 4 weeks. So more than 4 weeks, that mean will classified as long-term feeding. If less than 4 weeks, you might consider it to be a short-term feeding. Now, so what criteria are we going to use to determine the type of feeding tube or the route that we are going to use? So this flowchart is the summary of everything. So we have enteral nutrition. Of course, enteral nutrition, we have both oral, which is sieve feeding, and supplementation. So these are for patients who are able to take feeds orally. But we have tube feeding. So under tube feeding, we have jejunal. So this is a tube that is inserted by a nose to the jejunum. I'll show you the picture. Or by a mouth to the jejunum. Then, of course, we have duodenal, and then we have gastric. So under tube feeding, these are just the organs by which the tube is going to land on. So for instance, for jejunal tubes, these are for patients who maybe they have challenges with digestion and they can only absorb. Maybe let's say, for example, we have a tumor embedded in the stomach. So therefore, the upper part of the stomach is not able to practice or to function well. That is at the pyloric area or the cardiac sphincter area. Then that is usually you know that that patient will only require nutrients that are going to be what we call semi-elemental nutrients. Already they are digested, pre-digested feeds, they require absorption. Then, of course, for the duodenal also is the lower part of the small intestine. We have that also. So gastric is the tube that are going to be to fall either through via nose to the gastric, to the stomach, or they are going to be inserted in the stomach region. So it means that digestion is still okay. So now when we look at jejunal, further, we have surgical jejunostomy. So this is the insertion of the tube via surgical means. Then, of course, we have extended gastrotomy. So extended gastrotomy is a gastrotomy tube that is extended to the jejunum. So it can work. It originates from the stomach, then it goes up to the jejunum. Then, of course, we have nasojejunal. So this is the insertion of the tube from the nose to the jejunum. Then for the duodenal also, we have extended gastrotomy. So insert the tube in the stomach to the duodenal. Then, of course, we have nasoduodenal from the nose to the duodenum. Then we have gastric. So gastric, we have gastrotomy tube. We have esophagostomy tube, pharyngostomy tube, and nasogastric. So I'll show you the picture so you'll be able to see them. So all these define where the site at which the tube is inserted. Then, of course, surgical jejunostomy, also we have different methods that we do surgical jejunostomy. So we have what we call fine needle catheter and direct access. So these are just the methods by which surgeons use to insert the tube. So I hope it is clear. Then, of course, we have gastrectomy tube. So this can also be inserted surgically when you have surgical gastrectomy, which is usually the commonest. Then we have radiologically inserted gastrectomy. Then we have PEG tube, we term percutaneous endoscopic gastrectomy tube. So under that. So this is the criteria of which the tube the tubes are the routes of access for enteral is determined. So what will help you to know, is it jejunal? The tube is, are we going to feed via jejunum? It means that maybe from the stomach going upwards, it is not functional. Either the tumor is embedded in the stomach, we have that is going to prevent digestion of feeds. Then, of course, for the duodenum, you know that either we are going to have these are patients who their stomach have been affected by the tumor itself, cancer itself, and even the jejunum, the upper part of the tube. Or these are patients who have undergone resection, for example. Then, of course, for gastric, you know that basically the stomach is functional, and therefore you need to give feeds via the stomach. I hope that one makes sense for you and you've understood it. If you have questions, kindly don't hesitate to type in the chat so we can be able to address them. Now, so this diagram basically explain now what happens. So for tube feeds, of course, there are those which originate from the nose. They can go to the stomach here, which we call nasogastric tube. They land in the stomach. Then still it can come from the nose to the jejunum, which you call nasojejunal or nasoduodenals, or they can go to the duodenum or to the jejunum. The jejunum basically is the upper part of the small intestine, then the duodenum is the lower part of the small intestine. So basically, there are few nutrients that usually are absorbed at the duodenal compared to the jejunum. Mostly absorption of nutrients occur at the upper part of the small intestine. Then, of course, we have a tube that is inserted through the opening at the jejunum is called jejunostomy tube. And of course, we have a gastrostomy tube here. And remember also we had talked about esophagostomy tube is inserted through the esophagus uh, to the stomach. Basically, this applicable for head and neck cancers that maybe, let's say, for example, a cancer that had affected the mouth. Um, Maybe we have the nose part, the tumor embedded there, that mostly those patients now you have to consider esophagostomy. Then remember we have a tube which is inserted through the stomach, then it comes all the way to the jejunum or to the duodenum, and that is the ones that we had termed in the first slide. Like we can have extended gastrotomy or extended for both jejunum or extended gastrotomy for both duodenum. So these are how the routes of these are all the routes for enteral feeding. So you need to understand where you are going to your patient will fall. I can see time running. I want to really rush so that I'll be able to cover as much as we can today. So I've spoken about short-term and long-term qualification. So short-term enteral access feeding tubes are mostly placed when enteral is expected to be of less than 30 days in duration. So if you're going to give enteral feed for less than 30 days, then you can consider those are terms as short-term. For instance, pre-pyloric tubes or nasogastric tubes are the most frequently type of tube used for short-term enteral feeding. So this may be applicable for cancer patients who either are going for a surgical procedure, and after surgery they'll be able to do what? To feed. You'll transit them from enteral feeding to gastric. So that can help. Or basically for patients who are undergoing chemotherapy and they'll have to require they're going through chemotherapy and they'll be able to require the the they are going through chemotherapy and a short while. Let's say maybe they are doing a chemotherapy for 3 weeks. Those patients you anticipate for short-term parenteral feeds. Just give me a few minutes. I'm not seeing Lillian, and she said, I'm not seeing your request. Just seeing your request. All right, so let's proceed as we continue. Okay, there she goes then. Okay, so she started. All right, so we are looking at short term. So nasogastric tube, NG tube placement is one of the thing. Pre-pyloric endoscopic tube placement can be used. Then we have perioral endoscopic NG tube placement. Then we have what we call transnasal NG tube placement. So these are the way different means by which the tube are inserted, and I've shown you in the upper part how these tubes are inserted. So all these tubes qualify for short-term enteral nutrition. Then, of course, under nasoenteral tube, we have non-endoscopic. So basically, endoscopic, basically they are video guided kind of insertion. So we have we have the tubes are inserted by the guidance of an endoscopy. So interventional radiologists are able to guide us through that. Then, of course, we have the non-endoscopic post-pyloric tube placement. So, and then we have post-pyloric endoscopic tube placement. Then we also have perioral endoscopic post-pyloric tube placement, transnasal endoscopic post-pyloric tube placement, and what we have what's called double lumen nasoenteral tube. So these are just methods by which nasoenteral tube are placed. So let's look at in details nasogastric tubes. How do they function? How do we use them for feeding? So nasogastric tube placement is typically performed at the patient's bedside. So this is the commonest that you all know. And I know some of you, do we have anybody here who is able to insert it? Grace, Juguna, have you ever inserted nasogastric tube? And maybe Prudence, have you ever inserted nasogastric tube?
Hello, Okinda. Yes, I've inserted several
Okay.
kwa newborn, also adults. It
Great.
is just a simple procedure, nothing to worry about.
Great, great. Nice. So this is a procedure that you need to learn because it is the simplest procedure. For me personally, I've inserted so many, especially for newborns. It's so easy because I think they're so easy compared to adults. Adults sometimes they feel irritation and they can give you problem, but for newborn children, it's usually very easy to insert. So we are going to look at it in some few details. So it's the first choice. This method requires little training, and it is the first choice for the majority of patients requiring short-term nutrition. The NG tube is inserted from the nares, of course from the nose, to be distally placed in the stomach. The NG tube delivers enteral nutrition to the stomach and thus constitutes the most physiological method of enteral feeding. Then the stomach can tolerate higher feeding rates and increase food density compared to post-pyloric feeding. Typically, 8 to 12 French gauge NG tubes are utilized, and feeding can be done by bolus or continuously using a mechanical pump. So feeding can either be done by bolus using a 60 syringe cc, or you can have it as a continuous flow, and we'll be able to look at both the advantages of and disadvantages of those feeding methods. So basically, this is what we are talking about. So you need to elevate the head at the head part at 30 to 45 degrees. And then, of course, as you can see, the patient, you need to have that kind of angle. You need to sterilize or make sure that the tube is under a sterilized condition. Then, of course, the patient needs to bend their head backwards. Then you can insert the tube. So this is the way, so that this helps so that the tube doesn't go to the lungs. Yeah. So the head needs to be elevated backwards so that you don't miss the tube goes to the lungs. So now this is an inserted tube, and you can see now it is inside. It has gone up to the stomach from the nose here. The tube has gone to the stomach. The patient can even lie at any time the way they want, and they can even walk with it. So it is not that something that can give problem. So for short-term nasogastric tubes and the different tubes that I've explained, it really can help. Then long-term enteral feeding requires the establishment of permanent access to the stomach or small bowel syndrome. And cancer patients who qualify for long-term, I've said those are cancer patients who have had head and neck cancer, who are going for quite aggressive radiation therapy, and this is going to affect their feeding. So we do what we call prophylactic, either gastrotomy or prophylactic jejunostomy. What I mean by prophylactic is means that we are not inserting it for treatment per se, but we are inserting it just to make sure that the patient uh, is going to feed as continued with the treatment. So percutaneous endoscopic gastrotomy PEG tube is one of the most famous long-term enteral nutrition route. Then, of course, we have radiological or sonographical guided gastrotomy. So this is, of course, by the use of video guided. Surgical gastrotomy, we have jejunal extended PEG, we have direct percutaneous endoscopic jejunostomy, we have surgical jejunostomy, direct or fine needle jejunostomy. So all these qualify to the long-term enteral feeding approaches. So I've picked PEG for us to just understand how it works. So PEG tube is basically the precondition for PEG placement is that endoscopic or gastrotomy passage is possible. So you can make sure that at least by if you the esophagus is okay and you'll be able to insert it. Then before the start of PEG procedure, coagulation parameters should be able to be checked. So basically, you need to check if this patient is on warfarings, because sometimes bleeding might occur. So coagulation profile is quite important. Then complication of PEG are most often bleeding, which is usually 0 to 6% to 1.2% of patient cases. Tube site infection, 30% to 3 to 30% cases. Intraperitoneal leakage is not quite common, but it can also occur. Perforation of small and large bowel, metastatic head and neck cancer to the PEG exit site, which is another interesting case, but again, it is less common, like less than 1% of cases. We have something we call buried bumper, migration of internal disc or bumper into the gastric wall. So that can also occur when we are talking about PEG tube. So those are some of the complications that you might anticipate for such patients. And of course, feeding via PEG can be started as early as 2 to 4 hours after placement after an uncomplicated PEG procedure. So you find that many surgeons really do advocate that you do 12 hours, but if the procedure was not complex, 2 to 4 hours after it has been placed, then you can start with clear liquid diet. Then of course you transit to full liquid diet, and then you can go further to the blended and all that. But early feeding is rarely practiced, and most endoscopists start to feed their patients only 12 hours after the procedure, following an early preliminary trial with water. So many people prefer to do it 12 hours after, but 2 to 4 hours after placement, if there were not any complication, it's usually advised for that. Then, of course, we have what we call skin level gastrotomy. This is also another type of feed tube. So tubes are low profile device and are less socially stigmatizing. It has been shown that they improve the patient's quality of life. Let me tell you, for example, cancer patients who have a gastrotomy tube, many a times they really um, they fear walking, because if they are to walk with the tube, sometimes they feel somehow what can I say? They feel the stigma on it. So to prevent that, especially now, let's say for example, we have youths and Gen Zs with the cancer, and they also still want to go out with their friends. Then for such patients, this skin level gastrotomy is the ideal way for them. So they're usually used in young persons who find normal PEG tube protrusion socially unacceptable and patients with peristomal complications. And there are three types of so-called buttons available with two different retaining elements, balloon and retention dome. The external connecting system can be easily removed, and only a small skin level head of button remains between the feet. I'll show you the picture. So this is basically what we are talking about. So you'll find the tube here has been inserted, and you just have a small part. So nobody will ever tell that you have the tube inside of you. Yeah, so it is quite the easiest one, and the most appropriate that we can use. So this is the type of skin level gastrotomy. It's also known as a button. So they're usually placed once the PEG track has formed, not before 4 weeks after PEG insertion, but can also be inserted in a simple single step endoscopically. So initial button placement should be done under endoscopic control to avoid misplacement. So these are just procedure. I will not be able to go through that so much, because again, these are more technical these are more, I just place it here for us to understand that we have different types of the tubes that we can give. However, we have some of the comparison of PEG tube, that is for the jejunum, and then what we term as established PEG tube for jejunal, and also we have direct percutaneous endoscopic. So there are those tube there are PEG tube that are inserted in this can be achieved with jejunal extension. So we already have the jejunal extension, then you have the PEG tube, and then we have those which are inserted directly to the jejunum. So remember, the jejunal extension are the one that, like gastrotomy, extended gastrotomy tubes to the jejunum, and also extended gastrotomy tube to the duodenal. What are the comparison if you compare the two? Let me go back so I can show you what we mean to a certain so we are talking about gastrotomy tube, which has been inserted here, but it is going to be extended to the jejunum or to the duodenal. So what are the comparison? If you compare that one and the one for which you just insert the jejunostomy direct from the jejunum, what are some of the comparison? Which one is the best? So for PEG tube that is inserted through through the extended, we have vomiting. So patient experience vomiting, they experience aspiration, gastroesophageal feed reflux, then they also have gastroparesis. Meanwhile, for the ones that are inserted direct to the gastric, from directly to the jejunum, they have gastric resection, PEG not possible, recurrent dislocation of PEG, gastric outlet stenosis. So these are some of the things that you need to put in place and to have in mind. So you need to inquire from the surgeon how they inserted the tubes. Then, of course, we have surgical access. So this one also is another way. So this is a technique for enteral feeding are necessary when percutaneous endoscopic placement is not possible. This is most often the case when endoscopy is impossible due to tumor obstruction. So for such patients, you need to consider what we call surgical access. So for them. So basically surgical access will be able to look at the um, when we have huge tumors, especially in the stomach or going down up to the jejunum, then the surgical access is the one. So the fine needle catheter jejunostomy is frequently used alternative, especially when jejunal access is achieved during upper abdominal surgery. So don't worry, we'll be looking at which feeds is able to go to the jejunum. Tomorrow, I'll be able to give you all those formulations. So if you have a patient, you don't have to worry. I have all that list and all that prepared with pictures for you to now have that idea. Then also we have a large bore needle is tunneled subseriously before entering the jejunum lumen and their feeding catheter. So we have different methods that we can use. Having looked at those different tubes, let's look at now management and delivery of nutrients. All right. Have we understood that part? Does it make sense? Was it complex? Are we together? Have I lost you? Let me hear from the audience. If we are still together, I might be speaking, yet some people were lost long time ago.
We are following.
We are following, eh? Great. All right. So let's look at delivery of nutrients. This is where now the rubber meets the road. This is where the rubber meets the road. So for today, we look at different delivery methods. Then tomorrow, we'll be able to look at the formulation and a case study so that we link it up. So we have two important delivery methods. We have bolus and versus continuous feeding. I'll have to confess this. I know in this forum, we also have my colleagues, nurses. Nurses love bolus. They rarely love continuous feeding because they feel like continuous feeding will really make them still somehow kind of committed to the patient, especially when they have many patients to attend to. So they just love something that they give it one off and it is done. So we look at advantages and disadvantages of each one. So there are two principal methods to deliver enteral feeding formula through the tube. So we have continuous feeding and intermittent feeding, which is also known as bolus. So in bolus feeding, a measured amount is slowly given by syringe over an identified time. The rate of administration should not exceed 30 ml per minute. This is where now I need you to take time. It should not exceed, the rate of administration should not exceed 30 ml per minute. Why is this important? Because many patients who are on bolus feeding usually experience a lot of diarrhea. And many a times when they start having diarrhea, you'll find other healthcare providers questioning nutritionists which feeds they gave. Yet the feeds they gave was just in order. It's only that the rate of administration was too fast. So this patient experienced malabsorption and also diarrhea. So it should be 30 ml per minute. So you give 30, that 30 should go per minute. So some nurses or some of us do push the syringe. True or false? Anybody who has had experience of delivering nutrients, see, some push it like a drug. Sure, that's it. Do you agree?
Yes.
Yes, Daisy, what is your experience?
Especially from my hospital,
Mm.
they have too much workload for the day, so they don't want to spend their time there. waiting for it to flow. They will push it and go.
Okay. Sandra, what is your experience?
That's very true.
Yeah. So it should be 30 ml per minute. But we'll look at the consequences of that push so that we'll be able to help. And I hope after this webinar, you'll be able to have these notes, present to your team kindly. Go have a CME with them. Sometimes they do that maybe because they don't understand the consequences. So I hope we are going to have a CME in our various facilities. Then, of course, in continuous feeding, formula is delivered slowly but without interruption for up to 20 hours. In critical ill patient, continuous administration of over 24 hours via feeding pump is well established. So actually, for patients who have gastrostomy tube and are going home, bolus feeding is the one they need to do, and it is important for us to advise them to do 30 ml per minute. So they need to be educated so well, especially for home-based enteral nutrition. So in conscious mobilized patients, the majority can be fed via gravitation-based feeding system. So gravitation, basically you hang the feed up in the stand so it flows. Either continuous or bolus application of feeding mixtures is possible. The choice of method should take into account the patient's individual tolerance and personal wishes. So it needs to be very important for us to really consider patient's personal wishes. The advantage of bolus-based feeding protocol is that the time for the feeding procedure is reduced and the patient can organize his or her daily activities more individually. So they can take charge of their own life. But now you need to make sure that they do what they do it correctly so they don't have malabsorption and all that. So in the case that diarrhea or vomiting occurs during bolus application, the patient should switch to continuous feeding, starting with low feeding rate. Many a times we do stop feeding. Is it true? I'll still come back to you, Daisy. If diarrhea start coming, usually people say, let's stop feeding, let's stop kabisa kabisa. But don't worry, I'll be able to discuss the complications in details so that we see how to manage them. So this is what basically mean gravity, and this is the feeding pump. So you have the enteral feeds here. I know in Kenya we rarely have these feeding pumps. Prudence, have you seen them in where you've worked for enteral administration? Have you come across them? Prudence, is she still here? Oh,
Yes,
yes, yes. Oh,
nimeziona.
oh,
I've
okay.
seen them at
Yeah.
Coast General ziko.
Oh, okay. So if we don't have a feeding pumps, I'll be able to share with you another gravity set with a rate that you can regulate, that you can use for feeding, for enteral feeding. Nowadays we have different ones that we can give. So don't like feel like if you don't have a feeding pump, then that is the end of it. Now, let's look at some comparison here or on methods of administration. So we have bolus feeding. So initially 50 ml, then increase gradually up to a maximum of 250 to 400 ml of approximately 30 minutes, 3 to 4 hourly, daily in 24 hours. Guys, do you see now the recommendation? This is what we should do. We are saying 50 ml, then increase gradually up to a maximum of 250 ml over 30 minutes. So if we push 400 ml within 2 minutes, or we push it within 5 minutes, that patient will have malabsorption and diarrhea. Remarks: most appropriate when feeding into the stomach. Check aspirate before each feed. So you need to withdraw and check if they are aspirate, and you need to know how much you are getting. Feeds may poorly tolerated, causing nausea, vomiting. It causes vomiting, diarrhea, cramping, or aspiration. So these are the common complications that we usually have, and usually they originate because of the quick way of pushing it. Then we have intermittent slow gravity feeding. So 400 to 500 ml infused by gravity of approximately 20 to 30 minutes. to 1 hour, 30 minutes to 1 hour, 20 to 30 minutes to 1 hour, or 3 to 4 hour daily. So this one you can be extended up to 1 hour. Okay, but now you put a gravity set and then you allow it to move. So patient retains freedom of movement in between feeds, so you can disconnect and the patient can go. Improve tolerance of feeds because you're giving it a slow. So imagine 500 ml within 1 hour, that's the best. Then of course we have continuous. Total volume of feed required is slowly administered, approximately 100 ml per hour over 18 to 24 hours. So this is most suitable when feeding into the duodenum or jejunum, where elemental diets are most appropriate. May also be suitable for feeding into the stomach. Method may slow peristalsis and feeds are better tolerated. So now you have this flowchart. This one, even if you miss everything that we've learned today, you can have this flowchart and maybe print it and put it for nurses to guide them because they are the most people who feed our patients. So the instructions are as follows. 1, tube feeding should be used at room temperatures. Cold mixtures can cause diarrhea. That's another thing. So you find many a times nutritionists wana prepare kitchen feeds, wanakuja wanaweka bedside, wanaenda. Yes, maybe nurses could be busier, but they don't notify them. So this patient will be fed maybe after 1 hour, after 2 hours, or sometimes they forget to feed them. Cherono, do you have that experience? That the food comes from kitchen, is being placed by bedside, and that's it. Do you guys have the experience? Edina?
Yeah, I have.
Uh-huh. What usually happens? I can see
I
time.
have a ward. Okay, for
Mhm.
example,
Yeah.
in a female medical ward at Kerugoya County Referral Hospital, right now we have 60 patients and 2 nurses.
Okay.
And I am the only nutritionist who is rotating in that ward, and I'm expected also to be in the male medical ward. So I have support staffs or casuals who help me get food from the kitchen, and they bring it to the patient's bedside following the patient's diet sheet that is on the bedside. So they will come and place maybe the blended diet, and they will go. By the time I'm realizing
Normal.
that patient had not
You are
taken.
going home. By that time, you're going.
Yes, or else I'll find that my patients are even feeding 2 meals in a day.
My apologies, I got disconnected. I hope I'm back and you can hear me. I hope I'm back. You can hear me, okay? So I'm asking, maybe we can put it in the chat box. Hello, okay, I think I'm audible enough. Which strategies we can figure out, because now we have understaffing in our facilities and patients need to. So now we understand why patients really die in wards because of that. Anyway, ensure proper placement of tube and feed at slow, constant rate. Prescribed intervals and volumes of feeding should be adhered to. Care should be taken to ensure that the tube feeds meet the patient nutrient needs. Prepared mixer should be well covered, properly labeled, including time of preparation, and stored in a refrigerator for up to 24 hours. In the absence of refrigeration, quantities lasting only 6 to 12 hours should be prepared. All feeding equipment should be cleaned before and after each feed. All right. So then now some protocols. So intolerance to enteral nutrition in cancer patient is a frequent problem. Intolerance is one of the biggest problems that this patient experience. So this may result in increased risk of gastroesophageal reflux, aspiration, associated pneumonia, inadequate delivery of nutrients. So the basic procedure to reduce risk of reflux and aspiration is positioning of the body with the head elevated to 30 degrees. This is also something that we need to consider. Do we really usually consider that? Do we tell the patient to lie in a 30-degree? This has been shown to reduce incident of aspiration pneumonia. Then enteral nutrition should be commenced slowly and then increased to 40 to 50 ml per hour. According to the new study data, routine checking of gastric residual volume is not necessary in asymptomatic patients. So you don't need to really withdraw it routinely. However, in symptomatic patients with high gastric residual volume of more than 500 ml, adjustment of delivery rate and other measures are necessary. For instance, if you find residual volume is maybe 400, is 500, then basically you need that the stomach still has content. So you don't need to increase the rate of feeding. Drugs with promotility activity like metoclopramide, domperidone, both at 10 milligrams every 6 hours or erythromycin 20 to 50 milligrams every 8 hours are used to overcome high gastric residuals in clinical practice. So if you are having high gastric residue, it means that the feeds are not, digestion is not taking place adequately. So therefore, there are so much of it in the stomach. So you can help to assist the stomach motility. So the use of motility agent is associated with increased gastric empty, decreased gastric residual volumes, and improved tolerance to enteral nutrition. But the long-term use of motility agents is often limited by what we call tachyphylaxis. So tachyphylaxis is one of the things that this patient experience. And what basically it means, tachyphylaxis, it basically means that we are going to have rapid response to successive doses of drug, rendering it less effective. So basically, the drug might be less effective if we continually use it for long. So although small bowel feeding may be associated with reduced rate of pneumonia and increased rate appropriate nutrient delivery, nasogastric feeding is still preferred option. So that is what. Tube clogging. So we usually experience clogged tube for patients who are fed enterally. Uh, so a clogged feeding tube is reported in 23 to 35% of patients with a PEG. It's quite common. And risk of clogging are especially high when thick enteral feeds, especially hizo zenye Desi anasema kitchen feeds. And I think tomorrow I can get time to discuss, to compare the kitchen feeds versus now the enteral nutrition supplements. Bulking agents and medication are delivered through relatively small PEG tubes. I know my colleagues in Prudence here love also to give their drugs via the NGT, and sometimes this is common to cause tube clogging. So since pH values below 4 have been described to promote protein coagulation, repeated gastric residual aspiration should be avoided or minimized. That way, you should do that. If possible, all medication should be changed to liquid formulation, or this is not available, completely dissolve in water prior to flushing. Tubes should also be flushed with 40 to 50 ml water before and after delivery medications or bulking agents, e.g. resins. So it is important that we flush with that amount. Let's wind up on this last one. Then tomorrow we start at complications. So what do we monitor? It is important that we monitor some parameters when we are giving parenteral nutrition for cancer patients and even for other patients. So what basically do we monitor and why is it monitoring is important? The reasons I've stated there, but I would like us to look at why the things to consider. So you'll consider feed administration, check nutrient intake, delivery rates at interval to ensure even flow, measure gastric residue volume only if problems are encountered. Fluid balance. Fluid balance chart must be strictly maintained throughout enteral feeding. Check hydration status clinically. In patients with diarrhea, fever, or other non-physiological fluid losses, assess urinary output daily. You also need to check GI function, nausea, vomiting, constipation, abdominal distension must be checked to ensure tolerance of feeds. So this is basically the physical part, the clinical assessment or clinical monitoring. Tube and stoma, ensure daily that tube is in correct position. That should be done. Nutritional status, weigh patient daily, laboratory tests. Keep in mind that many cancer and acutely ill patients have insulin resistant and might develop diabetes mellitus under enteral nutrition. Serum albumin should be measured initially and then at weekly intervals because of its short half-life, that is 2 days. Pre-albumin better than albumin is useful to track changes of nutritional status in acute patients. So now, what do we monitor? This is my kind of last presentation. Then maybe I take questions before we end. We start tomorrow. So if you are giving a patient is on enteral feeds, cancer patient, the first thing that you need to check nutritionally, nutrient and fluid administration, that one you need to check daily. Is it okay? Fluid balance daily. Weight, BMI, bioimpedance analysis weekly or every second week. Those ones need to be done weekly. Tube and enteral related. So nausea, diarrhea, constipation. Constipation we can check daily or twice weekly. For nausea, diarrhea, those ones you need to ask daily. So you need to have a checklist. You ask patient, ulitapika, una ara, all that. Tube conditions and fixation daily. Stomacite daily. Then for clinical general conditions, you need to check if the patient is okay. Drug therapy daily. For laboratory works, what do you need to check? Sodium and potassium and glucose initially daily when you start. Then phosphorus, calcium, urea, creatinine, albumin, blood count initially twice per week. Albumin we do weekly, every second week. Pre-albumin weekly or every second week. But we've said pre-albumin is the best. Then functionality, what we call ECOG score. This one you can check. Hand grip strength, you check weekly. So these are the parameters you need to be monitoring. I know many a times we give enteral nutrition, but we rarely monitor these parameters. So I want to stop there for today. Then tomorrow we discuss complications of enteral nutrition. Then we can discuss a case study, and then I think it will be a good webinar. Let me open up for questions before we end. I know we have a few minutes to end. I open the forum for questions. How was the presentation? Have you learned something, or is there anything else that you want us to discuss? Questions and answer. Asanteni sana. Anybody with a question? You can unmute and ask. Christine Ogot, are you okay? Have you learned something? Banis, Mohammed, the only boy child in class. I would like to get your feedback.
Yes, I have learned a lot. Thank you. What I've learned, the takeaway from this slide, there are many, but I will give my feedback after the session in the chat.
Yes.
One of the highlights is the use of motility agents like domperidone, 10 mg. That was a game changer for me. I never considered if I want to improve the gastric residual factor, I need to use that motility agent to improve the movement of food from the small intestine to the large intestine.
Yeah.
That motility agent is a game changer for me, and I've learned a lot. The contraindication for enteral feeding. Previously, I used to rush enteral feeding, but now I will exercise caution.
Yeah.
I will take the contraindication. For example, like the severe function disturbance of the bowel, the gastrointestinal obstruction like ileus, peritonitis, stenosis, inflammation, metabolic instability like diabetic ketoacidosis, diabetic coma, hepatic coma, circulatory instability, severe acute cardiac insufficiency. I was not doing the check and balance. I was rushing enteral feed. The other thing what I've learned about the diagnosis results, like the phenotypic and etiological. What I've learned is the phenotypic part. It is the first time I'm hearing.
Oh, okay.
The other thing, the tool, assessment tool, you said for cancer, the most common tool is MAST.
Yes, must, yeah.
For I'm a renal dietitian. In
Yeah.
renal, we use both MAST and the subjective global.
Yes.
In it, a subjective SGA, subjective global assessment.
Yeah.
Can we still use SGA for cancer patients?
Yes. Actually, that is actually the number one. Then, of course, you can use most also. So, patient-generated subjective global assessment is the ideal one. It's help you a lot for cancer patients too.
Oh, thank you. I've learned a lot. I made a lot of summary notes. I
Nice.
cannot sum what I've learned. Please
Yeah.
share with us the slides.
I'll share the slides plus the recording. Oh, great. Thank you, Mohammed. That's a good feedback. Christine, I've seen your feedback. Daisy, anybody else? Mumin, I know you joined late. I don't know if you're still in. How was it? Charlene, Milka, how was the presentation? Grace Juguna, thank you, Bishara. That's quite commendable. I hope learning has taken place. I'd like to hear from other people before we close the class. Lillian, go ahead.
Apologies, I joined a bit late.
Yeah.
But it was a very informative and very educative session. And I think we should be having more of this so that we brainstorm, for some of us who are not in hospital settings, practicing out here with patients who are at home or something like that. We definitely need such refresher. So this was a good one. This was a good one.
Great. Yeah, by the way, it is very important to note that this is going to apply not only for inpatient, but also for home-based enteral nutrition, which again, there are so many cases. Cancer patients, many of them, they have this tube at home. So it is important for us to have this knowledge so that when we go to take care of them, it becomes very, very easy. Okay, so unless now we have a burning question, if not, tomorrow kindly join early because we have a lot to cover. I'll bring you a case study. And basically, we are going to look at calculations of enteral feeds. How do we calculate? How do we write prescriptions? Which enteral feeds should we give? Which types are there in the market? I have a booklet for that, so that at least we can know which one to give at what time. Otherwise, I think we end it there for today. I want to thank you for day one. Your participation was quite good and your attendance was quite good. I hope I've impacted information to you. And now we look forward for tomorrow. Then later on to what way forward can we have? Because I want these presentations really to inform way forward for us. Otherwise, thank you. Have a lovely evening. If there is no question, see you tomorrow. The link will be the same. We'll use the same link. Bye until tomorrow. Asanteni sana.
Thank you, Kinda. Bye.